Anyway, I'm a pediatric cardiologist. I have one disclaimer, I'm not a radiologist. So this is learning for me too. And then second, I don't have any fancy cine images because I'm not a radiologist. Okay. So management of congenital heart disease, as we know, apart from a fine anatomic or morphologic details, we need details of function, flow, and pressures. And this is what is a comprehensive assessment. And cardiac catheterization has for a long time been golden standard, right, for anatomic and physiologic assessments. I think even before echo evolved, initially the precedence was for cardiac catheterization, even for morphologic diagnosis. Now, because it is invasive in nature, it needs anesthesia and radiation exposure. We are trying to look at other non-invasive modalities as alternatives. And parallelly, we have a lot of advances in non-invasive imaging, and which we can call multimodality, or sometimes I may use the term advanced imaging also, has replaced most of the time the diagnostic cath. And so now cardiac cath pretty much has a therapeutic role. So we'll see that what are the advances in some of the images. Now, this talk will, when I call it advanced imaging, we are looking at echo, 3D echo, which has evolved. We have now real-time acquisition with a high volume rate imaging, which allows you automated quantitation of flows. And in addition, we have newer modalities like spectral tracking, tissue Doppler, and miniature devices. So these are all the recent advances. In CT also, we have now increased number of slices, and the resolution, both temporal and spatial resolution, has improved. There are modalities that are decreasing the radiation doses, and we now have better accuracy. Looking at MRI, I think I found a lot of information that I learned very advanced MRI techniques with the phase contrast and 4D modalities. And then there's a lot of overlapping with CMR and CT fusions are being done. And then the other modality, which we in pediatric cardiology use less, is the nuclear imaging and PET scanning, which have more in the adult world. So these are all the advances. And of course, we've heard about 3D models and virtual reality. So I'm not going to go into details, but these are also our tools in the armamentarium of advanced imaging. Now, I was looking at what are the current indications for cardiac catheterization, and I found this American Heart Association scientific statement. It goes back to about 10 years, 2011, but this is the only thing I found. So the class 1 indications according to this paper, so I mean, we've changed since the last 10 years, so I'll try and discuss, where we can replace this cardiac cath with advanced imaging. So of course, whenever you're planning an intervention, so you need diagnosis at the same time. So you want to diagnose of the degree of aortic stenosis and you're planning for an intervention, that's when you can use it. And then pH assessment and PVR and reversibility. Complex pulmonary atresia to define segmental lung supply. So pulmonary atresia, we want to describe the pulmonary blood supply for the surgeon. And then also whether there is RV dependent coronary circulation. And the other indication is transplant evaluation, whether it is preoperative or postoperative. Then class 2 indications are for assessment again of pulmonary vascular resistance in areas mostly like single ventricle palliation that our previous speaker was talking about. And then anytime the imaging does not provide enough information, that's another indication. And then assessment of coronaries in various situations. So these are the listed cardiac catheterizations. And we know for cardiac catheterization can be used for anatomical details, function, rarely so, hemodynamics. So our main focus would be hemodynamics, and then it also gives you tissue diagnosis by biopsies. So if you want to look at morphology, so when you want your patient to have a good morphological definition, I mean, we've seen some cases, beautiful cases that Dr. Saurabh was showing. So echocardiography is still the mainstay. So for those of you who are, young budding cardiologists, there's nothing like, doing a good echocardiogram. So take your time, be patient, and you can 99% of the time you can define the diagnosis by echocardiography. There is now transesophageal echo, wonderful, 3D images are available, both live in transesophageal echo and very good delineations of the valvular morphology. So we have that as our first tool. Then CT. So we have to know what is good for what situation, and that's what we're trying to focus in this session. CT is better for extracardiac structures than intracardiac. So this example shows you a nice supracardiac TAPVC here going into the SVC. Then coronaries. So for coronary anatomy, CT is much better than MRI. It gives you beautiful delineation of anomalous coronary arteries. And then there's 3D reconstruction of CT that gives you structures like this case where Yeah, there's Lacombe de Novo done post-transmission of great artery. So this is the kind of definition we get from CT. Then CMR, the latest, advanced imaging technique, it can do static imaging for anatomy. In addition to that, there's a phase contrast or contrast enhanced MRI. That is very good. It identifies inflammation, infiltrative conditions, and some scar tissues. And then we can do MR angiography for central and peripheral vasculatures, as I shows in this example. So there's a black blood imaging, there's a white blood imaging. So these are static images. This is a gadolinium enhanced CMR, which is showing a thrombus in the aneurysm of LV. And this is the MRA, which shows a nice coarctation. So these are some of the applications only. Now, just briefly to understand when CT is good and when MRI is good, CT is good, has good spatial and temporal resolution. So it gives better anatomy and better coronaries also. Then flow data, MRI. CT doesn't give you flow data. And then the acquisition is faster for CT, a little bit more for MRI, shorter breath hold for CT and a longer breath hold for MRI typically, but free breathing strategies are now available. And of course, the biggest difference is the radiation exposure in CT and not so in MRI. So looking at what morphology, some of the special cases where morphologic diagnosis can be given is this MRI, where for Kawasaki disease, especially if you have proximal coronary aneurysms in echo and you want to define distal coronary arteries, especially in the acute or subacute phase, I think CT would be a good alternative rather than going for an invasive angiography, unless you're planning on an intervention. So that's how you choose. And then I was looking at some of the post-operative follow-up of TGA babies that we want to evaluate coronary anatomy because of the translocation, and MR coronary angiography, this paper says, is a very good way of assessing. In addition to coronary abnormalities like stenosis, and so it will also evaluate the myocardium, any infarction, ischemia, things like that. Then, of course, the bigger, if you look at the indications that I showed you from the American Heart Association, pulmonary atresia IVS, I think, when I train all the children with, even now, I think all the babies with pulmonary atresia and IVS go for a cardiac catheterization to define the entire pulmonary blood supply. So the size of native pulmonary arteries, the ductal supply, any aorta pulmonary collateral. So we need a big definition of all this. So there are some interesting papers that have shown that CT is as good as Cath for evaluating pulmonary artery anatomy and AP collaterals as shown in this picture. So this paper has a good correlation. So this is the invasive angiography showing aortopulmonary collaterals and the similar picture of a MRI here. So a pretty good correlation they've showed. Here again, it shows you a very hypoplastic right pulmonary artery. From advanced imaging, you get the similar image. So I think this paper says that it is as good as Cath, and there are multiple papers saying the same thing. So CT is accurate for preoperative evaluation in tetralogy, pulmonary atresia, and MAPCAS, and is associated with substantially lower radiation dose. So when you compare the radiation dose of cardiac cath in defining PAs, then it is a little bit lesser. And similar paper again in 2020 says CTA and catheterization are equivalent in their ability to delineate PA anatomy and major aortopulmonary collateral. Like we were discussing, I think it is more of a mindset, what your surgeon wants. I think they're just used to seeing the invasive angiography pictures, but I think it's a matter of culture. So you show them the CT pictures, maybe sometimes you may have to do both and show them the reproducibility, and then they will start to apply it. And so that it's a matter of, changing culture. Same thing, MRI also you can use for defining AP collaterals. And another interesting paper I found about, what about, the RV dependent coronary circulation. CT and MRI will give you the anomalous coronaries connecting with the RV sinusoids. Not only that, the dependency depends on if there is any coronary stenosis associated. And this paper says that it has identified all the patients that had coronary stenosis. And so they conclude that coronary CTA is a reliable non-invasive assessment of RV dependent coronary circulation. This is a very recent paper in 2022. Then how about now we've looked at morphologic diagnosis, how about cardiac function? We won't spend much of our time because anyway, we don't use catheterization for cardiac function nowadays. In addition to, good assessment of stroke volume. So this is just an example of how it identifies the end diastolic volume and systolic volume and gives you a stroke volume. In addition to that, it also, the property of MRI is tissue characterization. So it gives you information about myocardial viability and scar also. And cardiac function, we know nowadays we can do diastolic function by advanced 2D and 3D echo, spectral tracking 3D echo. So all these modalities are there. So it's not really a Cath function. And nuclear imaging also, I won't spend much time on it. It's more of an adult application in inflammation, ischemic heart disease, and tumors that was so elegantly discussed. Now, another interesting area of advanced imaging is flow dynamics, right? The aspect we are interested from Cath is mainly flows, your QPQS, your cardiac output. So many papers are saying that, this can be done with MRI, the phase contrast, or sometimes also called velocity encoded CNMR imaging. So the nuclei traveling in the magnetic field develop a phase shift, and from that, these velocities and pressures are calculated. So this paper shows the non-invasive quantification of left to right shunts in pediatric patients. So for those that are new and not radiologists, so there's a plane scan at the level of MPA and at the level of LVOT, and then they trace this cross-sectional area of PA and aorta, and then it gives you flow. So nice aortic flow here and PA flow. And then this paper showed a good correlation, a very good correlation between the QPQS by oximetry and QPQS by MRI. I think I was actually impressed. Similarly, different paper by same phase contrast MRI, pretty good correlations between QPQS of oximetry and also the amount of left to right shunt by oximetry versus phase contrast MRI. So we have this available, and then the technique can be made faster, 60 seconds, I believe, less than 60 seconds by a technique called sensitivity encoding. And then how about repair tetralogy? We have a huge, patient follow-up of repair tetralogy that are, growing older, and we need to understand their RV function. And again, echo is not very good. CT is also not very good for RV volumes. The MR is the gold standard for RV volumes and function. So in addition to that, giving function and volume, it also gives you the regurgitant fraction. So this pink flow is the forward flow across the PA, and the blue is the reversal of flow. So it gives you a regurgitant fraction. This is one method. The other method you can do is, again, calculate flow across the aorta and calculate flow across the pulmonary artery, and the difference can be given as regurgitant fraction. So there are two different technical ways. How about the other important area that our surgeons want us to catheterize is the AP collateral flow quantification, whether it is in tetralogy of fallow patients or your single ventricle patients pre-Fontan or post-Fontan. And again, many papers in CMR that are saying that, we can quantify AP flow quantification. So the beauty of MRI is, I think any area you can choose, you can calculate the flows in those areas. So this paper has calculated, flows in different areas, and there are two ways you can calculate AP collateral flow. One is flow at the SVC and ascending aorta, and the difference would be your collateral flow, or the other is your main pulmonary artery and pulmonary vein, and the difference would be what is going through the AP collateral. So the AP collateral fraction can actually be quantitated, which again in cardiac cath, we cannot quantify flow. We can only image the coronary arteries, image the AP collateral. So I think the added advantage of MRI is that not only it gives you a morphologic picture of the collaterals, but also of the flow. Again, significant correlations are there between the two methods. In addition to that, it will also quantify how much is going to the right lung and how much is going to the left lung. So relative perfusion. Again, another paper that says differential pulmonary branch blood flow also MRI is able to calculate. So it calculates the flow at the main pulmonary artery, which is this curve, and then flow at the right pulmonary artery, and the difference between the two would be your left pulmonary artery. So selective pulmonary artery flows can be calculated, and this is as good as your perfusion imaging, as good as your VQ perfusion imaging. And how about resistance, right? The other thing apart from flows, we are worried or we want to get from cardiac cath is the pressure and resistance. I think this is where, cath is superior to other modalities, non-invasive modalities, but there are certain papers that are looking at how we can derive, not a direct estimate, but derivations of pressure and resistance. And there are some studies done in pulmonary arterial hypertension. So they looked at various things in the PA that are correlating. So they've calculated the average blood velocity through the cardiac cycle that are correlating with pulmonary pressures and resistance. And one nice study from, I wouldn't say nice, but an extensive study from Aspire registry is looking at how to correlate MRI with PA pressure and resistance. And the correlations are not very strong here, but they've come up. So they calculate the LA diameter index and the pulmonary artery diameters, and they come up with an invasive, with an indirect estimates of pressure. So the correlation coefficients are not very great, 0.75 and 0.67, but they do correlate with the cath-derived PVR and PA pressure. So although they are not correlating with the cath measures, but they are able to detect with significant area under the curve of 0.94 for detection of pH. So just the diagnosis of pH and detection of more than PVR of 3 is reasonably well. So again, this is a matter of doing more studies and understanding how it behaves. Then how about Fontan? Fontan also, we have patients that are that can have complications that we cannot keep on taking them to the cath lab. So I think this is where MRI can come into picture, both for anatomical complications, and then the GAD MRI gives you the vascular anatomy. You can calculate the single ventricular volumes of the fontan and phase contrast for pulmonary artery flows. We can do a separate right pulmonary, left pulmonary artery flows. Then, as I mentioned, we can do quantification of AP collaterals, which are very common pre and post fontan. You can look at myocardial fibrosis and thrombi. Not just this, you can also do computational flow dynamics. So see how, each shape of the conduit gives you a different flow dynamics, and that can be assessed. And however, like the question was asked, will the surgeons be comfortable in taking a patient for fontan without a Cath? Again, it's a matter of culture, it's a matter of surgeons. And even if we do a Cath, I think 50% of the time, there is no correlation between the results. So now some centers say you don't really need a cardiac Cath before fontan, but again, it's a very surgeon-oriented thing. And then how about heart transplant? How does, advanced imaging help in heart transplant? In acute cellular rejection, you have several echocardiographic techniques to predict rejection. And then the CMR can predict myocardial edema and necrosis, which are the hallmarks of rejection. However, the tissue diagnosis tends to be the diagnostic gold standard. Again, how about vasculopathy? Coronary vasculopathy post-transplant, again, stress imaging, dobutamine stress have been shown to be very predictive for vasculopathy, but nothing like, doing an IVUS and coronary angiography. So again, this is something that is evolving. So looking at all this data, can advanced imaging replace conventional Cath? I think it will depend on our philosophy of the institute, the surgeon, and I think it needs a little bit of a mindset. So, we are leaning towards it. I think the center where I do, I've really decreased the number of diagnostic Caths. So I rarely do any diagnostic Cath nowadays, unless it's a PVRI study or a pre-fontan or fontan. So the reasons we have to go for a tetralogy anatomy or coronary anatomy is not there anymore. So again, see what is beneficial for the patient. It's a little more radiation than CT. It's an invasive procedure. It costs more compared to, an imaging technique. So do that. And then, so I conclude that diagnostic Cath is almost obsolete, except the few situations that are fontan, the PVR PH studies, and tissue diagnosis biopsy studies. Apart from that, there should not be much of a diagnostic Cath. So it's going to be pretty much shifting towards interventional procedures in the Cath lab, and this may have a better utilization of Cath lab time, because those are the centers like us where we are competing with the adult lab time. I think reducing diagnostic Caths would be a good way to go for the hospital. And then coming the virtual reality and augmented reality will help in planning and performing complex cardiovascular interventions. And MR guided Cath labs are coming. So hybrid Cath labs with MR superimposition on Cath labs are coming. So that is interventional imaging is coming up. And as we do this, I think as cardiologists also, we need to be trained in CT and MRI. And unfortunately, if we decrease the number of diagnostic Cath, I think for the new fellows and the training fellows, it's a disadvantage. So I think you have to balance it out. Thank you very much. And if anybody is interested, there are AHA guidelines for appropriate use of multimodality imaging in congenital heart disease. It's a very extensively described paper which tells you which modality to use. I think it's a good reference for all of you. Thank you very much.